Hello everyone, my name's Steve and welcome to Keep Calm and Take X-Rays, Episode 1 Redux. You might be wondering why is this a Redux, because it's the first one you only ever published. The other one that I published I wasn't happy with and took it down and went off of YouTube forever. Well, it seemed like that anyway. But today I plan to give you an introduction into medical imaging. This whole series is basically about radiography and the whole thing of medical imaging. And I think medical imaging is probably a better term because diagnostic radiography encompasses CT, MRI, ultrasound, plain film, fluoroscopy, theatre, mobiles. So there's a lot of things which encompass diagnostic radiography, and it falls under the bracket of medical imaging. So this video is for anyone that might be considering a career in radiography, or anyone that's just curious and wants to find out what we do. And so therefore, I'm going to try my best to keep the medical terms to a minimum, or I'm going to try and explain them as best I can and try and keep things a little bit interesting. So what are we going to look at today? Well, everything has a starting point, so we have to look at, I'm going to give you a brief history of radiography. I'll try and keep it as brief as possible. I'm not going to go through all of the details of all of the different points at history, in which point, you know, somebody decided, oh, we can actually make a better transformer that powers the X-ray tube and all that kind of stuff, and just kind of go on the main one that triggered it all. What is a radiographer and what we do? What there is now after 122 years. Then we're going to look at plain film. It doesn't really refer to wet film anymore, but it's a term that's kind of stuck. We're going to look at theatres and mobiles, so doing radiography in a theatre and doing X-rays elsewhere in the hospital. Fluoroscopy, very similar to theatres and mobiles, apart from that they have dedicated rooms rather than having taking a generic machine to theatre. Fluoroscopy rooms have specific purposes, one dirty and clean procedures, and have different types of table movement. Then we have CT, formerly CAT, MRI, ultrasound, and nuclear medicine. And then we're going to look at some of the qualities that make a good radiographer if you're thinking to become a radiographer, and how do you become one, and is it all worth it in the end? That's something that you need to decide. And then I'm going to provide some useful links in the video description, because I don't know if you can provide them in the video. You probably can, but I'm not quite familiar with all of this putting overlays onto videos, which quite frankly I find annoying. So, a brief history of radiography. Anyone that's seen V for Vendetta, remember the 8th of November rather than the 5th of November. 8th of November, this guy. Who is this guy? If anyone knows, put your hand up. Although, yes, you, put your hand up. No, this guy is somebody called Konrad Wilhelm Röntgen, or Wilhelm Konrad Röntgen. It is written some various different ways. I'm not quite sure which one it is. So like with anything, there must be a starting point. It all started with this guy. So on November 8th, 1895, this guy called Konrad Wilhelm Röntgen, he was a German physicist attending at the University of Würzburg. I think I probably just butchered that name. On this day, on the 8th of November 1895, he was conducting some experiments. He was conducting experiments with these things. So let's just set my pointer to a laser pointer. So this is what's called a crux tube. You can essentially think about it as like a vacuum tube or a light bulb. And what he was doing is he was passing high voltage electricity across here. And he discovered that when he passed high voltage electricity across here, somehow, I don't quite know how he had it rigged up, it's not really important now. He had some high voltage electricity going across here, and he had some barium platanocyanide in a jar some distance away. And when he ran the experiment, this is a vacuum tube, by the way, so there's a vacuum inside here. Well, not a total and complete vacuum, but almost, at low pressure. And when he ran the experiment, this stuff here started to glow, and he wondered why. And so he ran it again, covered it in black cardboard, and it still glowed. That's barium platanocyanide under some sort of spectroscopy / microscope. So yeah, it still glowed after he encased it in a cardboard box. Essentially a black cardboard box, because he thought that with understanding of colour, people understand colour as black as being an absence of colour. Is what you're essentially seeing. So you're seeing an absence of reflected or refracted photons. And that's why something appears dark or black. And so he was wondered why the hell it did this. And so after he conducted this initial experiment, he got kind of a bit obsessive about it all, and lived in his laboratory for 7 weeks, much to the dislike of his wife, I would have thought. He even had his food brought to his laboratory. He even had his bed brought to his laboratory, and slept in his laboratory for about 7 months. Not 7 months, 7 weeks. After this period, I'd imagine his wife came to look for him. She probably came to look for him on other occasions, but she pretty much probably got fed up. I don't actually know the exact story behind it, but I could imagine that she got fed up and went to look for him. And a couple of weeks later, I think on the 2nd of November, is it this? No, it won't be the 2nd of November. 22nd of December, something like that. He ended up taking this picture, the very first ever X-ray in existence. And so on this day, our profession of radiography is born. So if you're wondering what this is here, it's her wedding ring. We believe it's her wedding ring. And obviously it looks a little bit like a potato, but you can recognize that you've got metacarpals here. And then you've got your phalanges and a wedding ring, creating artifacts. It took about half an hour to take the first ever X-ray, coincidentally. But she didn't have too much of a great comment on the actual whole event itself. She said that she'd seen my death. I'm not sure if that's a poor German translation, or whether that was some notion relating to the fact that it used ionizing radiation to take the image, and that was her comment on it. And so that is the discoveries X-rays, essentially. So this German physicist, Konrad Wilhelm Röntgen, on the 8th of November 1895, ended up creating and forever changing medicine. Not creating medicine, forever changing medicine. So let's go on a quick recap. So on November 8th, 1895, X-rays were first discovered by Konrad Wilhelm Röntgen. He studied it in great detail for about seven weeks-ish. And in that time, he did get, even though it was a little bit obsessive, he did figure out every property that we know about X-rays, and they still stood up to scientific tests today. On the 22nd of December, I was right, he ended up X-raying his wife's hand and created the first ever X-ray. And so our profession of radiography, or radiographer, our actual title, is born. And then that's it, really. So, and after that, things spiraled, and we'll move on. So, 122 years later, things happened, and we went through all the process of discovering that radiation is kind of bad for you. It is very, very bad for you. In high doses, especially. Anyone Google Chernobyl or Fukushima, and you'll know that high-dose radiation is very bad for you. So, things happened in those 122 years. And we now have radiography, what we know as today. So, for those of you that aren't looking at the screen, so wet film gets an honourable mention. It's primarily been used up until the 1980s, so 1990s, probably 2000, until more recent advancements in computer technology. Now, X-rays were typically taken using a silver halide film, which was then had to be removed from a film from the actual film cassette that was protecting the film, that you had to then put in a developer, in a fixer, and then wash it and then dry it. And then it took anywhere between 20 minutes or longer before film was actually available to view, and you had to view it on a light box, which creates the problem of subjective contrast, although we still have that problem today in terms of megapixel monitors and various things like that. So, and it would use harsh chemicals in order to produce those images, and people had to work in a wet room, and they didn't, at the time, it wasn't really understood about Koch and Riddle and the handling of hazardous chemicals. And it's now a lot better for your lungs at radiography than it used to be. People used to be darkroom technicians, and that's how it all worked. But now it's moved to plain film. We call it plain film because we still kind of use a plain film, essentially, and it's just kind of a name that's stuck, essentially. Plain film is now basically what we refer to as CR, or computed radiography. Thanks to advancements in laser technology and the reusable film emulsions, well, not film emulsions, but reusable X-ray film or X-ray detectors or plates. They basically have a film inside that is sensitive to ionizing radiation, particularly X-rays. And when you take you make an X-ray exposure using the button, and then what that does, it creates a latent image, which is on the film cassette, and then you pop it in a reader. It's read using a laser, using Nyquist theorem to sample it. Well, Nyquist theorem is related to how it's sampled. It's read by a laser, and then it's blanked by a different laser, a blanking laser, and then it's fired back out and dropped back into the cassette and ready for reuse again, so you can reuse these. It takes about 20 to 30 seconds to read the film, and then now we've moved on. It's even quicker these days. You can literally press the button, and 3.5 to 2 seconds later you get an image, and that's called DR, or digital radiography. We do have something called DDR, not double data rate memory. It relates to direct digital radiography, and this is whereby the detector is built into the X-ray table. You don't have an actual cassette, as it was called. You have a plate or a detector, which is wireless usually. You can have a freestanding one and ones that are built into what's called the upright bookie, something that you stand up against to take a chest X-ray or any other kind of X-ray. And basically plain film kind of stuck. So if you work in a plain film department, any hospital, well, if you work in a plain film department, you might have DR systems, but it'll still be called plain film, even though there are essentially no films. We can still print film, but it's printed on a plastic kind of laser printed type affair, and it doesn't no longer use silver because there was a big... you used to have to put old films, or films that were being destroyed or rejects, you would have to put them in for recycling to get the silver halides back, because the silver was obviously quite valuable. And that is what plain film radiography is. So let's have a look at what your average plain film radiography room looks like. Let's change the pointer style here to the laser pointer. So what do we have? This is an OPT machine, orthopantanogram, I believe, and that's digital, that's DR, so the detector is built into the machine. And this takes views of your mandible. These are your lead gowns on a reinforced coat hanger, because they do weigh a lot. I think they weigh in the region of one... I don't quite understand how the stone systems work, but I do remember that it was between 1 and 2 stone, depending on the millimeter equivalent thickness of lead that is in there. These are lead-free as far as I know. I'm not quite sure what other chemicals that they have in them to stop radiation, but they do, or it's lead-impregnated rubber, or sometimes barium. So if you're wondering, an X-ray room is actually, can be lead-lined. They usually either are lead-lined, but it is cheaper to have what's called barium sulfate plaster, which is also very, very good at absorbing X-rays. And anything that absorbs X-rays has a very high atomic number. The reason that we like lead is because it has an incredibly high atomic number, and it stops that radiation passing through. So here is what's called a Bucky table, or an X-ray table. This is your X-ray machine, the actual generator that, well, the X-ray machine, or the part that generates X-rays are this thing here. And it comes out of here. This is your collimator, which allows you to adjust the light. If you've ever had an X-ray and there's that light, the square of light that comes out, you can adjust that, and that alters the area that you are going to expose to radiation as a radiographer. Then this is your table bookie with a moving grid inside here. So when you put one of our aforementioned X-ray cassettes in there, on here you can pick a abdomen or a lumbar spine, which you're doing here, and use a grid, which is used to stop scatter radiation. And the grid is a kind of a lattice of lead strips, and it moves to stop scatter radiation, but that's for another video. You can have moving fixed focus grids, various kind of grids. Don't need to worry about those. This is just really an introduction to radiography. This here you can just see off to the side. That is the control panel, and this glass here is not your average glass. This is lead. And this is lead-impregnated glass, so we can see the patient. It's a bit difficult to stand behind somewhere and not see the patient, what they're up to, because if they fall off that table, you're in trouble. Or if they fall over or fall off anywhere, and generally end up injuring themselves, you need to be able to see. And this is lead-impregnated glass, which can stop scatter radiation under up to 150 keV, or kilo electron volts energy level. For those of you who are radiographers or radiography students, never aim your tube this way. If you're doing a horizontal beam knee, don't bring your tube around here and aim it across this way. Don't ever aim towards that glass, ever. It's designed to stop scatter radiation rather than stop a primary beam radiation. So please don't ever aim towards there if you can help it. So I was talking about those CR processors on that X-ray plate. That's what one of those plates looks like. This is a photo that I took from my department and got rid of all the IT information. So this is your typical AGFA processor. It's just a variation on the manufacturer. Fuji, Canon, Toshiba, Philips, Samsung, I believe, actually do them now. The AGFA is very popular. And what happens is this is the CR digitizer. And so you have this cassette here. And you take a latent X-ray image, you expose a patient to radiation to take that image. You have a latent image on here, which needs to be read and digitized. You pop it in there. It takes the cassette down into here, reads it, and fires it back up into the cassette and pushes it back out here. All takes about 20 to 30 seconds. And then what it does, it sends it to wherever you've tagged it to, because you have to tag it with the patient information so it makes sure that that X-ray is tied to the correct patient when it's been dichemized. So these are what they kind of typically look like. You've got various sizes. So this is your 1824, I think it's centimeters, your 2430, weird size, and then 3543, typical thing. And this is another weird size one here. This is the OPT machine one, which is ultra wide essentially. I don't know about this. I'm sure either that's just a weird Photoshop thing when they're stacking them, but I'm pretty sure that that's just a weird size. It might be a skull unit size. Couldn't tell you, to be honest. That's what the normal sort of X-ray cassettes look like. It's pretty much a standard. I don't know about the United States, but AGFA are pretty popular. And these cassettes, they're very popular. I've been in 2 or 3 X-ray departments that have only ever used AGFA, and the other one was Philips. And they look very, very similar, although there was just purple rather than orange. And then we move on to 2016, which is, this is the Fuji. This video is not sponsored by Fuji. Fuji Devo DR detector, which is water resistant, basically urine resistant. That's what it's talking about. I can't imagine why it would get wet, but also it means you can wipe your detector with Clinell wipes. These are your retrofit, or can fit in a normal DR room, X-ray detectors that are fitted with carbon fiber. They've got a battery and are completely wireless. And when they're ready to accept radiation, you have to prime them to accept radiation. You fire it and it takes an image, and boom, literally 3 seconds later, your image is on your screen. And these are absolutely fantastic. They have great detail. They have even detail across a bit. You used to have to X-ray certain body parts in the center of the old X-ray cassettes. These are absolutely superb, and this is a credit to Fuji on that. I'm sure if Philips attempted to do some DR stuff, that they would be good as well. But Fuji have really outdone themselves. Well, I don't know if about outdone themselves, but really set the standard for digital radiography imaging. And this is their Devo kit, which can be retrofit into any X-ray room, and it is absolutely brilliant. You can store images on it. You can use it in memory mode. Say if there's a problem with the DR mobile machine, which we're going to go on to in a minute, when you go to do radiography elsewhere in the department, because you can take the machine with you, if there's a problem with the software on there, you can tell it to remember the X-rays and download them at a later date, which can hold up to 250 images. And it's a top-notch bit of kit, and it's tough for what it is. Although I think they need to do that because of how much of a battering they get in a plain film department these days. Which now means that we're going to swiftly move on to looking at all the good stuff that people like looking at. What's the worst ever injury that you've seen? I'm only going to do a few images, and bear in mind that this is only one image. In radiography, you should always do 2 orthogonal views, which means 2 views at 90 degrees for those of you uninitiated. Except for chest X-rays, apart from in the United States, it seems to be that chest X-rays, everyone seems to get an AP and a lateral chest X-ray. So this here is a spiral fracture through the distal humerus. So this is your humerus here. It's not a humerus injury. It is. No, proximal humerus, your shoulder, your scapula, your clavicle, bit of lung. And this is your elbow, and this is a resulting of a twisting injury. This person was arm wrestling and pretty much snapped their arm whilst doing that, I did take this film. So this is a classic one for second-year radiography students will recognise this. We tended, I think we had to do some sort of like project or assignment on lipohemarthrosis. And what that means is a fat fluid interface. That giant white arrow is pointing to the lipohemarthrosis. And what that is a fat fluid interface because you've got a tibial plateau fracture here. And what's happened is blood and fat have come out of the fracture site because bone has fatty bone marrow inside of it. And also blood because you've injured it. And it comes out and it creates what's called a fat fluid interface. Cross table means horizontal beam. So this person is laid on the trolley most likely. And that allows you to see that fluid level quite nicely. So I was talking about the two orthogonal views. You have an AP or a DP wrist and a lateral. Don't worry about the AP and lateral terminology just yet, but it basically means one from the front and one from the side. And this here shows a distal radial fracture. And so you have a look at it in that place. Oh, it doesn't look too bad. There's just a line through there. Well, actually, it has got a little bit of posterior angulation deformity. So, and it's a left wrist because of the marker there. And again, we move on to something that I was calling about chest x-rays. So we don't know whether this is PA or AP because it isn't marked. Although there was a general consensus that unless it's marked AP, you assume it's PA. You assume it's PA unless it's marked AP. So you've got your lungs here, these dark bits. These are with little sort of flustery bits inside. These are your lung markings. This is the arch of your aorta, the left ventricle, the right ventricle. And then this is your trachea. You got your spinous processes just here. Your clavicles, your lung bases, right and left hemidiaphragms. And you can see an awful lot of information on a chest x-ray, and that's why we tend to do them quite often, because you can get an immediate answer. Does somebody have a chest infection? Does somebody have a pneumothorax? Does somebody have X, Y, and Z? And they're very, very useful in those terms. So we're going to leave that there, and we're going to move on to mobile radiography next. Mobile radiography refers to us being able to take x-rays pretty much anywhere. It doesn't refer to taking an x-ray with your mobile phone. So there are limitations, severe limitations on the type of examinations that we can do portably or on a mobile. In theory, you can do anything portably as long as there is a good enough reason to do it. But we'll go into the types of things a little bit. That's for another video. Commonly the things that we do, well, we have to make, when we do x-rays portably, like I was saying, we can do pretty much anything portably, as long as there is a good enough reason to, and we need to take in consideration IRMA and IRR 99 regulations. IRMA stands for Ionizing Radiation Regulations for Medical Exposure, revised in the year 2000, and IRR is Ionizing Radiation Regulations that was formulated in 1999. And these are the rules that we abide by when we're practicing radiography. They're very in-depth and need a separate video in themselves, but basically it's about radiation protection. So what x-rays can we do portably? Well, it varies between trust, really. But I would usually say that most of the time you can have a chest x-ray portably. And resuscitation, they can have chest x-rays, as well as a lateral cervical spine, a chest x-ray, and a pelvis x-ray. And this will all become apparent as to why in a minute. It tends to be a clinical emergency when somebody is asked to be x-rayed portably because they're too unstable. Or there's a clinical risk. So if the patient's unstable, that means that they're failing to do something, not as in like they're failing at life. It means that they're not ventilating properly, so their oxygen saturations are dropping, their blood pressure is dropping, which is an indication of at some point that they might go into cardiac arrest, which is something that you don't want. And so a clinically unstable patient gives us a good enough reason to do a chest x-ray if there's a reason to do the chest x-ray. It goes back to IRMA and the process of justification. And so that's why we do things portably. The common places that we can do things portably are resuscitation. Now, for those of you who don't know what resus means, it's short for resuscitation, and it's the sort of emergency room in the US, and it's where people go that either they've had a heart attack, their heart stopped, they've had severe trauma, things like that. An ITU is the place where they go afterwards when they have been stabilized, but they're still unstable to leave the ITU or ICU, in a nutshell, basically. So let's go through what it looks like. You may have seen these if you've been around a hospital. So on the left-hand image is the mobile art evolution from Shimadzu. It has to be said with an anime character voice, or Shimadzu. Shimadzu! It sounds like an anime character. And this is the GE tank. I call it the tank. It's the AMX4 Plus. They contain lead-acid batteries. This one has lithium in it. This has lead-acid batteries in it, and it will probably still around when the bombs fall and, you know, everything's flattened to dust. This will still remain because they are built like tanks. They weigh about as much as a tank, and this will take a door off or take a lift out before anything. It'll probably go through a wall because the motors and the way that this is built inside is an absolute monster. So let's move on and have a look at some portable images, because everybody likes looking at portable X-ray images. So this is a horizontal beam lateral cervical spine, and it's showing you a fracture of C3. So this is C7, and then this is C6, C4. So there's a fracture of C4 body there, and then they've riffed it and fixed it. So I've got a little bit of a zoom going off there to show you that. So more cervical spine injuries. So this is a hangman's fracture. Let me just try and get my pointer working. Laser pointer, there we go. So if we look, this is C7, the spinous process of C7. So 7, 6, 5, 4, 3, 2, oh, shit. You know, that there is a hangman's fracture, and that can result from motor vehicle accidents. It can result if you don't have a seatbelt on, and what happens is that you lunge forward when you are suddenly deaccelerating, and it results from forceful hyperextension, so you head shift back, and distraction of your neck, so your head's pulled backwards, and it pretty much pulls your body of C2 off of C3, and it's called a spondylolisthesis of the axis, and it's a fracture of the pars interarticularis, I think. Yep, of C2 on both sides, so it kind of splits and falls forward. And this thesis stands for moving, and spondy means vertebral body, and it slips out of position. Now, another reason why we do portables, so that's serious considerations to patient management. If somebody's got that, you can't be rolling them around, sliding them up and down, sitting up and down. You need to get that stabilized, and you need to sort that out pretty much quickly. You need to get them transferred to a specialist centre if you don't have the facility to deal with that kind of severity of injury. That needs sorting pretty much straight away. It can result in paralysis from that vertebra down. That needs sorting out. That's, you know, it's a good enough reason to have a look at that. So they've got a fracture, we need to be careful with him, we need to log roll him. That's the type of method to minimise movement to the cervical spine. And then there are other indications. So that's the lateral cervical spine. So now we're going to move on to why we do chest x-rays. Now this is a relation to something that can commonly occur. Quite commonly do them for pneumothorax. This is related to trauma. And when we're talking about pneumothorax, it means that we've got, in your chest wall, you have your ribcage, sternum, thoracic vertebra, connective tissue, and various other things. And you have the pleural sac, and you've got different types of pleura. So you have the pleural cavity, the visceral, and the parietal pleura. Visceral means that it's touching the organs, and parietal means it's not touching the organs. And in between, you have a fluid-filled sac called the pleural cavity. And what happens is if you have a chest wall injury, it punctures this and fills with air. And it's a disparity in the air pressure in the lung, in the chest wall, and so it ends up with the lung collapsing. And a pneumothorax is called a collapsed lung for those that aren't aware of the correct naming convention, I suppose. So this is the collapse there. It's an absence of lung markings. This is not the best image. It's very poor quality GIF. But you can see lung markings all the way across, that from the right ventricle across to the right side of the chest wall. They've got lung markings going across. You're going there, oh, there's this line, and there's no lung markings across there. That is a classic example of a pneumothorax. I believe the next image is going to show us another massively labelled pneumothorax, right-sided pneumothorax there. So you've got all these lung markings that you can see on this side. They extend all the way across to the edge of the chest wall. But if you extend, oh, there's a change in density, and the lung markings don't extend across there. And what happens is the lung collapses, because of a pressure differential between those two membranes, and so the lung can't correctly inflate. And that's why you get the absence of lung markings, because it collapses. It's a pneumothorax. Again, this is kind of keeping in the theme with trauma. Again, excuse the potato image. I can only assume with what is called an AP supine. Very nice handwriting there. So this is an example of something called a flail chest. It probably looks more like a potato chest to the uninitiated. But down here you can see rib fractures. And just to note, if you hurt your chest wall, we don't tend to do rib fractures. If you have them, the main concern is if you have a pneumothorax, not rib fractures. Although rib fractures are uncomfortable and very painful, they don't change the way that you are managed as a patient. They are very, very painful, but if you take a picture of them, not going to do anything. The only thing that they will do something about is this, and this is what's called a flail segment. And this is whereby an entire portion of the chest wall has been fractured and broken off, and it uses blunt force trauma to the chest wall. And what happens here is you get a pulmonary contusion. So you can see here that there is air there, and the lung density has changed because of that contusion. So contusion is another fancy word for bruise. So you've got normal lung markings going across here, and then it's increasing density because blood is bleeding from the lungs, like when you get a bruise on your leg, but you have a bruised lung. And this is a life-threatening condition because what happens when you breathe in, you get something called paradoxical chest movement. Although I am getting a bit technical here, but when you breathe in, you normally breathe in and your chest moves outwards. But when you breathe in with this one, your chest moves outwards. That segment of chest inverts and moves inwards. And when you breathe out, it within the chest wall going down, that inflates outwards. And it's the reason that it's so worrying is because damage to the lungs. Bruising to the lungs, it means that the lungs become stiff. So when you bruise your leg, that part of the area becomes stiff, and you require extra inspiratory effort, and it increases lung resistance. So it creates poor airflow, and it usually leads to respiratory failure if this isn't treated. And they do actually orif it. They actually put metal pins to fix the chest wall back in place to stop that happening. So that was the about on chest x-rays. So I was saying in resus you can do C-spine, chest and pelvis. So let's move on to pelvis x-rays. Now this is a normal pelvis x-ray, and you can see that everything is roughly intact. Even if you're uninitiated, to the initiated, you've got what these are called the iliac crests. These are your sacroiliac joints, and these are your hips. This is the right hip and the left hip, and the symphysis pubis here, which is the fusion of the whole pelvis. It's kind of a ring structure. Imagine it like a polo. And then you move on here, and you've gone to resus. You're a radiographer. You've gone to resus, and you've checked this image, and oh, you've got that. And so what we're looking at here, again, this is a life-threatening injury, and this is what's called an open book fracture. Now, the pelvis, as I said, is a ring structure and kind of like almost folded like a book. And what happens is if you're ran over by a vehicle, it can split that. And what you have here is disruption of your sacroiliac joints, and you have disruption or severe disruption of the symphysis pubis here, or the symphysis menti. And that means that this person has had a crush injury, and it's literally split the pelvis in two. If you was a doctor and assessing this, you would feel the left and right hemipelvis, and it wouldn't be stable, and usually that indicates bleeding into the pelvic cavity, and you have your main iliac, you have your descending aorta, which splits off into the left and right iliac arteries and femoral arteries, which if you have a crush injury like this, which splits your pelvis, there tends to be a worrying amount. There's a high clinical likelihood that you will have injured one of your blood vessels, and you may end up with bleeding into the pelvis. So that's why we can do those sorts of examinations portably: C-spine, chest, and pelvis. So a book, as you can see there, is opened up like a book. So we've got just another example there of an open book fracture on the left-hand image, and the other one which was done portably. Again, there's if you're a radiographer or a radiographer student watching this, there is huge emphasis put on getting the crests on, what are called the iliac crests, on pelvic images in cases of trauma. Now here you can see that they've got a massive open book fracture, Whereas and you've missed off the crest here. Now that open book fracture is probably of more concern than any injury to the crest here. But here you've got an injury to the right hemipelvis or the iliac crest, which runs straight down here and through here. This is the pubic ramus, and there's a fracture through there, as well as a fracture right down the right hemipelvis or the right iliac crest, and that gives you an example of the importance of why we have to get the crests on, and also some examples of why we can do certain examinations portably. And so we just need to remember with portable examinations, what we do is well, it's X-rays that we do portably, and we have to make consideration to IRMA and radiation protection, and the how it will change the management of the patient. And now we're going to move on to theatre radiography. Is this a scalpel I see before me, or is it a figment of my mind? An actor turned cardiothoracic surgeon, from the play that we won't talk about. So theatre radiography doesn't mean that it's theatrical. My friend always makes the joke when I'm going to theatre that he imagines it as if I was going to theatre in a theatrical sense, and we were always all very dramatic when we was operating on somebody. But no, this actually refers to X-ray examinations done in theatre. It can be interesting, and it is interesting, but it's not as exciting as maybe theatricalness. Maybe if we did it like a theatre production, it might be a little bit more interesting, so we could find out. But theatre radiography varies on trust and speciality of the hospital that you work at. Some hospitals, like major trauma centres, primary trauma centres, will pretty much do anything and everything in theatre. The pictures appear immediately, and we can do moving images. But the most common things that you will come across as a student radiographer, or the most common things that we do in theatre, are dynamic hip screws. These are pins that we put in usually old people's hips when they fracture them. They have a fall and break their proximal femur or the proximal hip, and it's called a dynamic hip screw. And then for fractures that are further down, we tend to do something called a PFNA, or for proximal femoral nail with anti-rotation. It will all become apparent in a moment. And then ORIFs, various ORIFs of various types of various things. And urology work, PCNL, percutaneous nephrolithotomy, which basically just means we stick something into the kidney to pull the to basically pull out a stone. Or if we can't pull out a stone, we'll put in a nephrostomy instead, which is basically an artificial opening to the outside of the abdomen, which allows urine to drain from the kidney because the ureter is permanently blocked for whatever reason. So an example, I spoke to you about DHSs. This is a DHS. It sounds like a DFS, but it isn't. Terrible. So this is a DHS, or dynamic hip screw. We put these in under fluoroscopic guidance. All the surgeons do. So they make an incision here and down here, and then they drill into the hip. They put in 2 pins. They put in 2 K wires to stabilize the fracture. First of all, they manipulate the limb. They put 2 K wires in to stabilize the fracture. They drill up here, put the screw in, and then put a plate in. And there you go. That's how they fix a proximal femur fracture. This looks to be on quite a young person, but it's not necessarily limited to young or old people, depending on whether you fracture it or not. So that's an example of that. I'm going to keep it quite short for theatre because, like I say, it's highly variable. Unfortunately, I do apologise. I believe the next images are potato quality because it's actually hard to find a decent image of a PFNA because no one really knows what they are. So as you can see here, this is the head, the femoral head, and this is the neck of femur here, and these are the greater oh, and there's a fracture. And so what's happened here, it's fractured below the neck of femur here, and so they can't put a screw straight through there and place it at the side. They have to stabilize the whole thing because this is a weight-bearing limb, the femur. It needs to be stabilized properly. And so what they do is they do something very similar to a DHS, with the fact that they put in 2 screws here, and anti-rotation is what these secondary screw refers to, and it prevents this prosthesis that they put inside from rotating inside to make sure that the person walks correctly after they've done this procedure. And so they drill literally all the way down to the bottom of your leg, just above the knee, and then they make a small incision, put this pin in there, and put 2 pins in there, and a metal wire or band that you can see around there to hold this part in place. It all sounds very simple, although this procedure takes about 4 hours, so it's not as simple as what I'm making it sound like in a TLDR situation. So, example of ORIFs. So this is an ankle fracture. And what we do is, an ORIF stands for internal open reduction, so they open up the limb and internally fixate it, or internal reduction, so they reduce the fracture, and then put pins in it, because I can't imagine that would be too comfortable walking on, just leaving it. So it's an alternative to a cast. Ideally, they try and manage fractures conservatively as best they can, but if it's involving the joint, it tends to end up having to go to theatre and have some metalwork put in it to help repair that. So swiftly moving on to the PCNL, or percutaneous nephrolithotomy. So percutaneous means to go through the skin, and nephrolithotomy means the removal of kidney stones. So nephro stands for kidney, and litho means stone, and otomy, removal of. And that's basically all it is. But we do it under X-ray guidance, and the patient's laying prone, so laying on their front, and they use an ultrasound machine to help guide a needle into the kidney, and then they put contrast into the kidney to show you where it is. So what you're seeing here is the collecting system, or the calyces of the kidney. This is the nephroscope, and this is a retrograde guide wire that comes up, and it helps to create a tunnel between the skin surface and the kidney. And that is what a PCNL is, in a nutshell, really. So we're going to move on to fluoroscopy. So let's all take these silly fluoroscopy jokes and bury them. Thank you, Patrick. So it's similar to theatre radiography, but uses specialised equipment. And we have two types of procedure: clean and dirty. Oh, terrible impression. It's not really that exciting. We do some examples of clean procedures. They're not really clean. Both are technically clean, but the other one is more interventional in terms of going into blood vessels, whereas the other one is going into the bowel, or imaging the bowel. And so you need to take, sort of same or similar precautions in terms of sterility, but that's why we separate them apart, because one room requires different types of table movement as compared to the other. So more clean procedures, whereby we have to have full face masks, things like that, is coronary angiography. Coronary angiography looks at the heart. More specifically, it looks at the blood supply to the heart. And it looks at how well contrast flows through them, and how well blood is flowing through them. And it looks for any narrowing in those coronary arteries. And if we're a primary centre, these can be stented and ballooned, depending on where you are. If you have a vascular surgeon as a backup. Pacemaker insertions, pretty standard stuff. These are either done, these can be done mobile, or these can be done in the actual room. It's a lot better if it's done in the actual room, because there's a lot more space, and it's a little bit less radiation dose to people. Peripheral angiography is the same as coronary angiography, apart from that we don't image the blood vessels of the heart. We image peripheral blood vessels, so anywhere in the body, basically. Anywhere in the body. We image anywhere in the body that may have an occlusion, so a blockage in the blood supply. We inject contrast dye into those blood vessels, and we can look at those blood vessels and see if they are, in fact, occluded. And that is peripheral angiography. And then we have joint injections. So these are kind of anesthetic injections and or steroid injections that you can have into your spine, into any joint in your body that you like, really. It depends on the speciality of the orthopedic surgeon or doctor that is doing the procedure. And now we're going to look at some coronary angiography. So this is a catheter tip here, this here, and it goes up and round the arch of the aorta. We put a catheter in your groin, and then we pass it up and round the arch of the aorta, and then we pass it through the coronary, around the coronary sinus, and into the various blood vessels. So looking at the left coronary artery, and this is the left circumflex artery. So you can see that this black portion here, or dark portion, is one of your blood vessels. This is the left circumflex artery. and you can see that it's nice and wide. We've got lots of contrast coming down here, and then, oh, there is an absence of contrast here. And what you're seeing is, because it's a tubular structure, you're seeing an absence of contrast because you've got a plaque build up here. You've got a narrowing of the blood vessel here, which is obstructing the blood flow to this portion of the heart here. And so everything distal from there, the blood flow is going to be a little bit slower than it is coming here because it's obstructed, and you get collateral growth around that to help combat the problem of the reduced blood flow through here. And it's the it's a partial occlusion of the left circumflex, I believe. So I believe, if YouTube is working, that this is a nice example of some coronary angiography. And that just shows you exactly what it looks like when we're in the room. Well, not exactly what it looks like, but this is just taken from YouTube just to give you an example of what it's like. So they're moving the this is a catheter tip. Let's see if I can get my mouse back. This is the catheter tip, and they move it around in the coronary sinus in order to aim it down the very different blood vessels, and you get pictures of it. So got different sides. This is the right coronary artery. And then we'll move on once the video is finished, if I can actually press next. So that's pacemaker insertion. So we've done coronary angiography. I was talking about pacemakers. These are the two wires that we put in. You can have a single lead or dual lead pacemaker. And what this does is, usually there's an electrical problem with the heart. And so the reason that we have two wires, we have an atrial and a ventricular lead, is because there's a conduction problem between this portion of the heart and this portion of the heart. And so what that does is it detects a initiation of the heartbeat here, and because there's a conduction problem, it can't pass down here, and so the heart doesn't beat correctly. And so this compensates for that and hopefully stimulates this portion of the heart to beat correctly. And we put that in under fluoroscopic guidance. These little squiggly bits here are literally kind of like needles. Well, they're not needles, but they kind of grab onto your myocardial tissue. That's the inside of your heart, the myocardium. And they spin these round and they embed themselves into the heart tissue. So you've got what it looks like under fluoroscopy, and then you've got what it looks like on a chest x-ray. And now we're going to move on to, I mentioned about peripheral angiography. I have got some different types of angiography, although this comes under more very specialized examination. So we've got peripheral angiography of the hand, and this looks to be an angioma, which is a vascular tumor of the hand. And this is neuroangiography. So neuro relates to the brain, and angiography being that we're putting X-ray dye into those blood vessels to show them up to see if there's any occlusions. And these are carotid arteries, left and right carotid arteries either side. And then we move up to the circle of Willis. And that's what that looks like. That's done in more specialist centres for neuroimaging. We have got an example of an MRI or an MRA angiography. That's slightly unrelated, but I don't know why that's in there. But hey, enjoy the image. So other sort of dirty procedures, barium and water-soluble enemas. We don't really do these anymore. I think we've done maybe a couple I've been qualified, well, I've been practicing for 4 years. And in that time, well, I specialised in fluoroscopy after 2 years. And those 2 years afterwards, I think I've not really done any barium enemas. They've either been done when I've not been there, or they have been done as CT coronography, which is something that you don't need to worry about just yet. So barium and water-soluble enemas. Barium is a type of metal. It's a heavy metal. And what it does, it's got a high atomic number, which means it's able to absorb a lot of X-rays. And it has the advantage of being inert, if you remember from GCSE chemistry. It's like kind of similar to an inert gas, like a noble gas. I'm just using an analogy here. It's probably not, but it can be thought of as being inert whilst inside the bowel. So with a barium enema, what we do is we pass a catheter into your rectum. We fill it up with air, well, your bowel up with air and water with barium in. And it acts as a double contrast agent, so you've got air and barium to coat the bowel wall, and we can look at how well, look at your anatomy. Then we've got it's more sort of gastric procedures you'll find out with this. ERCPs, endoscopic retrograde cholangiopancreatography, just rolls right off the top. This looks at the biliary system. You have your liver, pancreas, and gallbladder, and they all drain their various secretions from their respective locations down through something called the biliary system. And that exits out of the ampulla of Vata, or the papilla of Vata, depending on how you look at it. And that is basically, or the duodenal papilla. We are moving away from using the ampulla of Vata because somebody called Vata discovered it. Excuse me. And so what we do is we usually sedate somebody, and we pass a endoscope down, and we use a guide wire. We pass a guide wire up. We pass a guide wire through the ampulla of Vata, and we inject some contrast dye, and that shows the biliary system. And we're looking for stones. If anybody has gallstones or anything like that, you tend to have quite nasty epigastric pain on your right-hand side. And this is what happens. So you get those stones, and it causes an occlusion. And so the idea of an ERCP is to treat that, so it's both a diagnostic and a therapeutic procedure. So then we have barium swallows and meals. A barium swallow looks at the swallowing reflex as well as the condition of the esophagus, and looks for more motility problems. It looks at more at the esophagus, the stomach, and sort of the proximal duodenum. It doesn't look all the way down. Whereas barium meals tend to follow it all the way through from the stomach down to your rectum. Right, and so it's sort of separated into two halves depending on where exactly your problem might be or where you're having pain. So we've got an example of a barium enema. So this is the contrast pooling in the bowel. I don't know whether this is a supine or a prone view. Supine means that you're laid on your back, and prone means that you're laid on your front or on your tummy. And so you can see the contrast. This is the barium, the liquid barium. And the darker areas that you're seeing are air, and you can see that the barium's passed all the way around the bowel quite nicely, and it's coated it really, really well, so you can see all of the anatomy. Then we have the ERCP here. This is the endoscope that we pass down. So flexible endoscope. This is the guide wire that we pass through, and then we inject some contrast into there. I believe that's the pancreatic duct, and that's the hepatic duct. Could be completely wrong. I'm sure you will correct me in the comments. And then we're going to move on, and I'll show you some barium swallows. So this, you can see there that the patient has got a bolus of barium in their mouth, ready to swallow. And then the consultant will, or one of us will say, can you swallow that down? And then we'll acquire some images as they swallow down, so we can see how well they are functioning. So I've just separated some out here. You can look on YouTube, and there are various videos of this where you can actually watch it in real time as it happens. This is also part of a barium swallow. So, like I said, we just look at the esophagus and the proximal gastrointestinal tract. So this is the stomach. This is the pylorus and the pyloric junction. And this is the duodenum moving into the ileum around here. I'm not going to give you a detailed explanation of the images because at this introductory stage, I don't think you need to have one. So now we're going to move on. Now, let's look at the world of computed tomography, or CT. So, what do we know about CT? Well, everyone remembers everyone knows a joke about CAT scans. Well, there was one on the previous slide. So, computed tomography was formerly known as CAT scan, and the reason CT stands for computed tomography. And computed tomography, tomo means movement, and graphy is to take a picture. And it was invented, well, that's what computed tomography means, and the A in CAT scan was dropped because it it's technically computed axial tomography. And axial means that you scan somebody from top to bottom, and it was kind of assumed now, well, it's assumed now that it will always be scanned axially because it doesn't scan in any other way. The data can be reconstructed into different planes, but it is always scanned axially, so they dropped the A. And wonderful motorbike, just ruining everything there. So it was invented by this chap. Do we know who this guy is? This is Sir Godfrey Hounsfield, and it was invented in 1972. And he got a knighthood as well as a Nobel Prize for his contribution to medicine. And computer tomography, in a very closed nutshell, it uses a rotating X-ray machine that's collimated to a very, 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 very thin X-ray beam, 0.625 millimeters thereabouts today, and it has a bank of about 64 to 128, 256 detectors that are all 0.625 millimeters thick, and the detector and X-ray tube rotate around a patient in order to take an image. So it looks very similar to the one there. So the X-ray tube is housed inside here, and it spins around like mental. And I'll find some images later on for that. You can Google CT scanner internals to have a look at those. So it had massive implications for medicine. And like I said, it uses a rotating X-ray tube to basically make 3D images of the human body. So now on the next slide, I've got an image of the very first potato. No, it is not a CT scan of a potato. It is the very first CT scan ever produced by Siemens, or possibly Siemens, but it is very, 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 very blurry and very pixelated. However, this was a revelation at the time. And so move on to 2016. And, well, let's just have a look at the image and what you can actually see, despite the fact that it is very poor quality. So, we don't want that. We want a laser pointer. So these are your ventricles inside your brain. These are fluid-filled. You can see bone around the outside, and you can see grey matter as well. Now, obviously, this was a revelation time because you couldn't see that at all before. And now you move on to 2016 and look at the huge detail improvement that you've got now on modern CT. So this is a axial slice from a CT head scan. So you've still got those ventricles here. It's just a different slice through the head. It's referred to as a slice because you look at all of the images. So you've got cortical bone around the edge. You've got grey matter and white matter. These are your calcified choroid plexi. And it's a massive, massive improvement over what you could see back in the day. And anybody that has a head injury now or a stroke can have a CT head scan. It can tell whether they've had a bleed, an infarct, skull vault injury, so whether they've actually got a fracture to the skull. A massive amount of information. You can give contrast to look at vasculature, lots and lots and lots of things. It's not just used for head imaging. So we're going to move on from head imaging to thorax imaging. So, any of you remember the thing about DVTs or deep vein thromboses and people on planes and getting home and then dying from them? This is what can happen. So, if you're wondering what the hell we're looking at a slice taken through somebody's chest, and what it is a pulmonary embolus. So, I was mentioning DVT. So, DVT is a deep vein thrombosis. Usually, it originates from in your leg. And it's essentially a blood clot that breaks off, and it can break off, because a DVT can remain localized and stay in your leg, and it can give you clot-busting drugs to get rid of that or treat that using something called new and novel anticoagulants. And what happens is sometimes it can break off and form a clot in your lungs, and the two white arrows here, red arrows even, are pointing to a very big pulmonary embolus. And what happens is it breaks off and lodges in your lungs, and it blocks the blood supply to your lungs. So this is your pulmonary artery, and it splits off into your left and right pulmonary arteries. And this here was what we would call a filling defect or a pulmonary embolus that extends between both the left and right pulmonary arteries. Yeah, I'm just giving you some example images. You don't need to worry if you can't particularly understand that. You can Google it in more detail. So, and one other cool thing about CT data, it scans in the axial plane, it acquires a shed load of slices. The average chest-abdo-pelvis scan is usually about 1,500 slices that you can scroll through. And then it reconstructs them in various different planes. But I was talking about the reconstruction. Because these slices are so thin, you can stack the slices together and create a 3D rendering of whatever you're looking at. So this is showing a mandibular fracture. And then usually when you fracture your mandible, it fractures in two places. So we've got a quite obvious fracture through there and a fracture that doesn't completely extend all the way through just here. These are just some CT scans of your neck. And then they've reconstructed these scans in the axial plane. That's not reconstructed. You've got the sagittal plane and the coronal plane. But I wouldn't worry about those too much just yet. And now we move on to magnets. MRI, magnetic resonance imaging. How do even magnets work? I'm not quite sure, if I'm honest, but I do have a reasonably good idea about how MRI scanners work. Now, they don't look like your typical magnet that's in this background picture here, but your average MRI scanner kind of looks like this. And it is very similar in the ones that we used to make at school, an electromagnet. So this is your average MRI scanner. And if you've ever been in if you've ever been in one or worked in one, you'll be familiar with what they look like and what they sound like. And MRI scanners use basically a huge magnetic field, 60,000 times stronger than the Earth's own magnetic field, and they're measured in Teslas. So Tesla was a eccentric scientist, and your average MRI scanner is between 1 and 3 Tesla rating. So the strongest ever field strength MRI that's generated and is stable is 91.4. The highest one used for actual people that can get inside it, human beings, is about 10 Tesla. The absolute strongest field strength ever achieved is in the region of 750 Tesla, but the equipment destroyed itself. So MRI uses a giant superconducting magnet. Let's get some laser pointer going. This is the superconducting magnet inside here. It's encased inside of liquid helium. And the reason being, liquid helium, when it's at a liquid, it is down to almost absolute 0 Kelvin. And what this does, it allows wires inside here to superconduct. It means they have 0 resistivity, or 0 ohms. And it means that it can generate absolutely monstrous magnetic field strengths. And so that's how that internal part works. The outer portion of the MRI scanner is encased in some insulation, and then it has a vacuum insulator over it as well, because a vacuum is a very poor conductor of thermal energy. And that is sort of your overall view of an MRI scanner. How it works? Well, how do even magnets work? Well, your body is made up of probably 75% water, and water is made up of H2O, hydrogen and 2 oxygens. And the funny property about hydrogen, there's a lot of it in your body, and when you subject hydrogen atoms to a strong magnetic field, they align themselves in certain directions. An MRI takes advantage of this. And so basically there's something called Brownian motion. All of the atoms in your body, even though they're arranged in a way as such that is you, all of the hydrogen atoms are kind of sort of processing around as they would like. And so once they're placed into a magnetic field, these processions, so if you imagine that their atoms are sat as they are, but they're just kind of wobbling about, and then their atom is kind of processing on an axis. So if you imagine the Earth processing on its own axis, spinning around, it will process in a certain way. And I think I'm probably getting in a bit too much detail, so what I'll just say is that they process in a certain way, they're exposed to a huge magnetic field, and they process differently. They process either facing north or south. And then what happens is we use a powerful radio frequency pulse to destabilize these processions, so they switch directions. And when these processions switch directions, they give off a radio frequency pulse in return. And so it's picked up by the scanner's detecting coils inside. So we're going to move on and have a look at some pretty pictures of MRI scans. So these are two T2 weighted images of the brain. So if you remember, they're very similar to CT, apart from that they are acquired using magnets and the patient doesn't have to move. And ideally, we don't want the patient to move during an MRI scanner because the acquisition time is quite long. So what we're seeing here is a picture of the brain from the top, or an axial image, and a sagittal image. If anyone's interested, these are T2 weighted images. T2 means that fluid, so this is cerebrospinal fluid, that is surrounding the brain is bright white, because these are your ventricles that are normally filled with dark fluid on a CT scan, but they're showing up bright on this MR image. And we're going to move on. So we've got the brain, very classic images there. This is more musculoskeletal stuff. So this is a knee, and this is a Baker's cyst behind a knee. I'm not going to do too much detail because that's, I don't really do MRI. I want to specialize in fluoro. But I'm just going to show you some pretty pictures so you can have an appreciation of what some of the images look like. Again, this is just an introduction into medical imaging. And we can do some very funky stuff. Using different principles and field strengths and gradient coils and various other things, we can achieve some absolutely wonderful images. Now, the Muse Second Law album is actually not just a randomly generated picture. This is actually something called MRI tractography. And what it does, it uses a imaging technique that I won't go into too much detail about because it's headache-inducing. And it's called diffusion tensor imaging. And it was developed quite recently, I think 2007. Don't quote me on that, though. It was developed quite recently. And what it allows the MRI scanner to do is to look at the actual nerve fibers that interconnect the different parts of your brain in very, very high detail. So the Muse Second Law album cover was not just a fancy picture of the neural fibers in your brain, although most people probably didn't know what the hell that was, but it is a legitimate picture. So you can see here that this would represent sort of your various lobes, and then the fibers that come down and connect them. And it's the same on this one, although obviously if you're not familiar with this kind of imaging, you're not going to be able to see it. But that's just sort of, an overall thing of MRI. We do lots and lots of other things with MRI as well. And that's just an overview. I can't really tell you much more, but we are going to move on to ultrasound next. So ultrasound scanning uses high-frequency sound waves that are inaudible to the human hearing range. The human hearing range can hear between, I can't remember, but basically we can't hear it. And the cool thing about it is that even though we can't hear it, we still can use it to look inside the body. And hit the like button if you recognize what the ultrasound scan is in the background. So a little bit of a history of the background of ultrasound scanning. So it was first discovered in 1794, or theorized. The piezoelectric effect was discovered in 1880. And then the first clinical use of ultrasound, there was something, basically after 1880, people kind of experimented with it, theorized it, trying different things out, experimented and whatnot. Then there was the use of sonar in World War I and II. And then the first clinical use was used by this guy, Ian Donald. And he was a Scottish physician who was he was a professor of midwifery, I think midwifery, at the University of Glasgow, from what I remember. And he had an idea, when he saw people working at the Glasgow docks and shipyards, they used to use ultrasound to have a look at the at metalwork on various parts of ships and metal things, or metallurgy. And he thought, could this be applied to looking non-destructively at fetuses? And it transpired from there. So fetal ultrasound is probably the one that everyone recognizes. Now, this diagram shows you pretty much how it works, essentially. So you have a piezoelectric ultrasound transducer, for the technical term. And the cool thing about the ultrasound transducer, it uses a piezoelectric material. Piezoelectric means that if you pass electricity through this material, it generates a sound pulse. Fair enough. But one other very cool property about the piezoelectric effect is that if you pass an electric current through it, boom, generates a sound wave. And then when the sound wave passes back, it also creates it creates an electrical charge. And so it can be used in both ways, and that's why it's called a transducer. And so we fire out a ping and then listen for the ping to come back, and based on how long it takes to come back and how strongly it comes back, we can produce a funky picture from that. So, and the reason it's very good for stuff like fetal ultrasound, fetal anatomy ultrasound, is that there is no ionizing radiation involved. There are sound waves involved, but not ionizing radiation. If used incorrectly, though, it can cook things. I have seen a demonstration of it being used to cook a steak. So there are still safety concerns, but not so much if used correctly by a trained ultrasonographer. So I'll show you some pretty pictures that you're probably all familiar with if you've had a child. So this is showing your baby, and this one on the other side is showing you a kidney. And the thing that I highlighted here is showing you a renal stone or a kidney stone. And the reason that we know it's a kidney stone is that you've got all these echoes, these very grey lines that people just can't wonder what they are. And you've got changes in density depending on how quickly it bounces back. And so what you can see is very, very bright. So you've got a very, very, very loud echo coming back. But at the back, you're not getting anything coming back from there. So it's a very, very dense object. And behind it, you've got an absence of sound, essentially. This is a visual representation of a sound signal, basically. And so that there is a very dense object. And you think, oh, it's inside the kidney. So you've got here, which is probably fluid trying to pass out of the kidney in the renal calyces. And this is most likely to be a renal calculus. And now, so ultrasound also has some other purposes. We can view moving images, and the next picture is moving. So we have M mode, which is moving mode, and I can't remember what B mode is, to be honest. I don't do ultrasound. We also have Doppler ultrasounds, and I'm going to show you a picture of a moving ultrasound image of the heart, which is called echocardiography. I do quite like cardiacs, and so this probably doesn't make much sense to people, but it's a view of the heart, and this is called a parasternal long axis view, and what it is showing you is, if I can get some laser pointer stuff going off again, or even a pen. We'll use the pen, actually, this time. So here, although it is moving, is the aortic valve. This is the right side of the heart. And this is the left side of the heart. That is the right atrium, as far as I know. I'm sure left, even. And so what you're seeing here is, I probably shouldn't go through the anatomy too much, but it's showing you the internals of the heart, the chambers of the heart. And so what you've got here is, I'll switch to a laser pointer rather than drawing on it, because I don't think it'll make much sense to if you're not familiar with radiography, or you're not familiar with the images. So I think it's a bit unfair to go through that with people thinking, well, we don't even know, like, even the major basics of ultrasound. So let's just go to a laser pointer. And what you're seeing here is the valves of the heart opening up. So there's blood passing out into the ventricle, boom, out into the aorta. And what's happening here? You've got vegetation growing on the heart. It's endocarditis, and it's usually it's what happens when bacteria build up on the valves of the heart. And that's it, really. We don't have, I can continue to show you many images of ultrasound, but that is it in a nutshell. I do quite like cardiac ultrasound, though. So, nuclear medicine. Nuclear medicine is just as it sounds. We use something called technetium. You don't need to worry exactly what technetium is, but it is a metastable isotope, technetium-99m, M meaning metastable. And what we do is we tag that or bind it to something that attaches to a specific organ in your body, or a particular organ system, for example. So we have, we can do cardiac scans, myoviews. I don't know whether that's an actual copyrighted brand of the material, but nuclear medicine is good for one major difference, should I say, from normal radiography or medical imaging. Nuclear medicine looks at function because it looks at how much radio tracer has been taken up in a particular organ. If you give somebody an injection of something that, say, binds to your kidneys, and you look at the scan and you only see one kidney, now that could tell you that either A, that one of the kidneys is failing, or they were born without a kidney. And so, or if they've had an ultrasound that we went back to, showing that they've got two kidneys, and they do a nuclear medicine scan to look at the kidneys, but they only see one, what does that tell you? That infers that anatomically there are two kidneys, but one of them isn't functioning. And so nuclear medicine is particularly good at looking at the function of something. The images are quite potato. So what you're seeing here is, this is a CT scan, but then we can do SPECT CT or PET CT. It's just abbreviations for combining nuclear medicine and CT. CT providing the anatomical information, and nuclear medicine providing the functional information, and then they tie it together in these funky coloured pictures. So let's have a look at some of those images. So a nuclear medicine scanner, or a gamma camera as it's called, it uses gamma radiation. Technetium gives off gamma radiation. It has a half-life of about 6 hours. So it's, if you have a given amount of radioactivity in becquerels or megabecquerels, excuse me, if you have a given amount of radioactivity, it's say 300 or 600 megabecquerels, in 6 hours, that technetium will have degraded to half of that radioactivity and should theoretically be 300 megabecquerels if it started out at 600, and it takes 6 hours to do that. But this is your average nuclear medicine gamma camera. It's a Siemens gamma camera, and what it's doing is, once we give the patient an injection, well, in order to look at the gamma rays, we have to give an injection of that technetium bound to something. So we'll combine that technetium with a product that binds itself to lungs, for example, or kidneys, as I mentioned earlier. And then we give that a chance to circulate around the body and be taken up or not taken up in organs. And so we use gamma cameras to take a picture of it. I'm not going to go through the theory of how gamma cameras work because it's kind of complicated and it's too long for this video. So we're going to look at some scans. I spoke to you about the lungs as well. One of the popular ones is VQ scans, although they have declined in popularity. It's not sort of popularity. Nobody really wants a radiation dose in terms of usefulness, but it's quite common. And it's called a VQ scan. And you went, what the hell is VQ? And it's a ventilation perfusion scan. Don't ask me why Q stands for perfusion, but it does. And you have very nice images of potatoes, or very blurry images. But what you can see is the picture of the lungs. And the reason that we do ventilation and perfusion scans is, one looks at how well the lungs are ventilating, how well you're breathing. Because if there is an anatomical or structural defect in the mechanism of your airway in breathing, they can tell the difference to see whether you have something called a pulmonary embolism. And they always do a ventilation and perfusion scan. So these images are anterior and posterior. So you've got ventilation anterior and anterior perfusion. So this is looking at the air supply to the lungs, and this is looking at the blood supply to the lungs, ventilation, perfusion. And so we use radioactive krypton gas or xenon gas, and the patient inhales it, or a radioactive vaporizer, essentially. Or a nebulizer, not vaporizer. That's something completely different. And that looks at how well the lungs ventilate. And then we use, I can't remember the exact material because you don't really need to know it that much for this, but we use another material that looks at the blood supply to the lungs. And all these are variants of those images with different views, whether it's anterior, posterior, and we do left and right obliques, showing the lungs quite nicely. The lungs do show up quite clearly on these, but as you can tell, they are kind of like potatoes. Well, the image quality is about as good as a potato. Something a little bit more easily recognizable is a nuclear medicine bone scan, quite commonly done sort of looking at cancer and seeing if cancer's spread, how far it's spread, or if it's localized to a certain area. They will see if it's spread or not. And these are just anterior and different views. They just represents different views, basically. And the dots, the darker spots, are areas of higher radiation uptake. And this spot in the arm there is where the injection was given. The injection site is going to have a high amount of radioactivity. But over time, if you notice that where the injection was given, it hasn't suddenly flipped sides. It's just the direction that the camera is looking from. This is an anterior view, and this is a posterior view. So it's not flipped. That is the same arm there. It's just that it's looking from a different viewpoint. And as you can see over time, that it fades, and so that's what I would probably guess as to be the injection site. Nuclear medicine can also be used to look at the heart. I was saying about it looks it's good for looking at function, and these funky images are looking at the function of the heart. And this image here at the side shows you what we're kind of seeing. So we've got the heart, and we're taking some slices through the heart. And so what happens is if somebody has chest pain or has heart trouble, they can see, well, have you had a heart attack? Which means that an area of heart muscle has temporarily been starved of oxygen. And so they can see, well, if it's been temporarily starved of oxygen, has that heart muscle in fact died, or is it in fact resting? And so they do a stress and rest gated scan. And what these are looking at are the heart muscle and how well the heart muscle is perfusing. So we do long axis and short axis views, and so the brighter it is, the area is being perfused well with blood. And when you look at them between stress and rest, stress means that we give something to stress the heart and make you beat faster. Some places will put you on a treadmill and get you to run if you're having it as a patient. Some places will inject you with a pharmaceutical or a drug that will artificially stress your heart and make your heart beat faster. And what we're looking at is if your heart is at rest and they scan it and they think, oh, well, that area looks like it's died, or there's not much uptake of the radio tracer, then we're going to stress it and see if it reperfuses under the stress. And that's basically all that is. It's to see if it's resting or not, whether it's dead or resting. So, how do you become a radiographer? Well, this is mainly a perspective from the UK, so unfortunately for people in the United States, I can't really tell you because I don't actually know. So, radiography is currently a 3-year university degree course, and it's funded as of 2016 via a bursary, although you need to act fast because this isn't going to be the thing anything longer if our government has its way. It's usually split. And the degree is usually split between clinical placement time and academic time, and it's usually a 60-40 split. You can do clinical placement at partner hospitals with your university, and it gives you an opportunity to go to different places, and it can pretty much take you anywhere in the world. Clinical placement, by clinical placement, you go to a radiology department or a medical imaging department, and you practice radiography. So some universities will allow you to go literally anywhere in the world as long as you book it as a second year. And as long as you can provide funding or somehow get the funding, you can go literally wherever you want, the only barrier being language and transport. Some places like Canada were actually quite kind to my friend and sorted out with accommodation and various other things. But I can only vouch for there. Oh, let's go forwards. So it's assessed by assignment and practical assessments because everybody loves those. So, what qualities make a good radiographer? Do you think you're good enough for the job? These are just some of the generic skills that you will need to possess, although you'll get the opportunity to develop some of these skills or skills that you aren't so strong at. So they say in nursing that you should treat every patient as if they were their own mother. And I think this has a broad-reaching application as well to every medical professional. And it's very applicable to radiography as well. Although this will be extremely difficult with some of the patients that you have on night shifts that have had a little bit to drink and or other substances. So we've got caring and supportive, the one that I've just spoken about. I've highlighted calm under pressure. The reason being, I find this is incredibly important. If you become anxious, you tend to make mistakes. Being calm under pressure and kind of ignoring all the other stuff that's trying to distract you and get your attention that doesn't really need your attention can lead to mistakes and radiation incidents. And so being calm under pressure, I think, is an important point throughout your career, because you'll encounter some very, very difficult situations, whether it be a cardiac arrest, where a person's heart stopped, if you don't know what that means, and you're having to try and resuscitate them, or you're having to try and take an x-ray of somebody that has been resuscitated, that's intubated, or somebody that has severe trauma and injuries with various limbs maybe detached, and or severe injuries, severe disfiguring injuries, that can be quite distressing, especially if you're x-raying in resuscitation a child or anything like that has had a cardiac arrest or have been in a severe accident. It can be a little bit distressing, and calm under pressure, remaining calm, doing your job, communicating properly, which leads nicely on a segue to communication skills, actually. So communication and interpersonal skills. As a radiographer, you're going to be working with a variety of people, especially other healthcare professionals. Well, they are other healthcare professionals who are in hospital, as well as patients from all backgrounds, ages, ethnicities, genders. And they're going to have varying degrees of illness, injury, and or lucidity. I don't know if that's even a term, but degrees of understanding. And you're going to have to be able to figure that person out and be able to communicate to them and adjust your communication appropriately when you're communicating with them in order to get the best diagnostic quality images that you can. And also appreciate the agendas of other healthcare professionals. For example, if you go to resus and you have to take an image, but they can't do a certain thing, or a doctor cannot leave that patient for whatever reason, they're literally. I have had to do this. We've had a patient with the chest drain being literally held in by a doctor, and I have been to somewhere where somebody's had their hand inside somebody's chest. And it's a little bit difficult to try and get them out of the way. So how would you deal with that situation? And it's being to be able to accommodate the needs of other healthcare professionals as well as the patients and work together to get that diagnostic image, but avoid exposing them to unnecessary radiation. Although be aware that we do operate under something called IRMA, which stands for Ionizing Radiation Regulations for Medical Exposure, and it was updated in the year 2000. And we used to have IRR, which is Ionizing Radiation Regulations from 1999. Own ideas kind of ties in a little bit with what I was saying about how we can get an image from a particular patient that has a particular ailment. Now, sometimes, unfortunately, everybody's different. Every illness is different, and illnesses can be incredibly challenging, whether it be even just a fracture. Sometimes people experience pain in different ways. Everybody's different, essentially. And having your own ideas about something and how it should be done, how can we improve, or what way is better for the patient or for you? And sometimes we struggle to image patients due to the condition, their illness, or their injury. And you need to be able to look at that patient. You need to be able to safely image that patient. And you need to formulate your own ideas about how you're going to do that in a safe way that results in a diagnostic quality image. That's what we mean by own ideas. We don't mean about saying, well, actually, this is wrong. We need to do it this way instead. You need to develop your own ideas from the experience that you gain once you're qualified. And also not being afraid to question how something is done because you think it might be better, or it turns out to be safer or easier or quicker. Confidence with technology. Radiography does have a fair bit of tech in it. You don't need to worry too much about exactly how stuff works. You will do for the exams. You will need to know the physics and principles of physics behind how CT, MRI, ultrasound, plain film, X-ray work. Although you won't need to know the internal workings of the circuitry inside of how stuff works, essentially. although you do need to know how an X-ray target works. And so, confident with technology, you need to be able to at least use a computer. We've now moved away from CR, which has kind of no computer intervention apart from the digitizer, to a point where now everything is completely DR, which is digital radiography, and it uses a computer. And for this one, all you need is a basic set of computer skills. You can't say, I don't do computers or things like that, because unfortunately you're going to have to use a computer as part of your day-to-day working. And 99% of the time you're going to use it. But it also, for those people that have been working radiography a lot longer, they do have the upper hand when the tech goes down, because various electronic systems go down, or if there's a power failure, anything like that. They know what to do when there's power outages, or there's software failure. And that's basically the point with confidence with technology. If you're good with computers, you should be reasonably good with radiography, and confidence in adjusting settings, but that's more to do. That will come later on. Adaptable. Can you move from one room to another and do something completely different without thinking that you're doing something else or being in a certain mode? So my easiest example of this would be, I'm working in the middle, but suddenly someone's gone off sick and they've had to leave the department. You're now working in CT. That's being able to adapt from working in plain film to working in CT. And another example of this, rather than adapting between different rooms, adapting to your patient. And we don't mean like adaptation or origins of the species kind of adaptation. We're talking somebody comes in and you do a normal hand x-ray. A normal hand x-ray is pretty straightforward, or a normal chest x-ray is pretty straightforward. Fine. What if you come in with somebody that can't move, that's on a trolley, and they've had severe trauma? You're going to have to adapt. You're going to have to adapt the way that you, one, talk to the patient, the way that you're going to do the x-ray. You're going to have to adapt how you do that and still get the same image. How are you going to get those images? And you need to be able to think, how can I change what I've got, or how can I work with what I've got to get the same diagnostic quality images, or images that are of comparable quality to what it would be to a normal person. And it's being able to adapt to their conditions as well. So I was saying about moving from plain film to CT, and as well as working in different areas from theatre. It's all going to change, or it can change quite rapidly where you're working from one room to another. Physical and mental stamina. We're required to work long hours. I work 12 hours a day, 3 to 4 days a week, depending on my rota and how many hours I've done. And when you're qualified, you'll require physical and mental stamina. Doing night shifts and on call, especially, trying to do certain x-rays at 3:30 in the morning while somebody is giving you abuse. Although most people would refuse to do that, or if they're unable to, if it's not their fault that they're giving you the abuse, you need to be able to, one, tolerate that and be able to work with them. Well, not tolerate it, but be able to understand that it might not be the patient's fault, but you still need to be able to get the images. But despite the fact that you've been awake for, say, 20 hours or 16 hours, you still need to be able to do what you need to do and do it safely. Working in theatre for a long time, you can be in theatre for up to 6 hours doing a particular case, 6 to 8 hours, usually between 2 and 4 hours, most cases, if you're not working in a hospital that has major trauma. And you need to be able to do a job exactly the same at 3 a.m. as you do at 3 p.m. or at 9 a.m. as you do at 9 p.m. or, well, 3 p.m. and 3 a.m. You need to be able to do your job exactly the same, and you might be required to work for extended periods on your own as well. I was saying, like with on-call, we used to do 16-hour on-call shifts, and you need to be able to produce the same quality images that you do when you're fresh in the morning as you do when you've been awake for 20-odd hours or whatever. Attention to detail and accuracy. With radiography, attention to detail is very, very important. How accurate you are in taking an x-ray, and it's, I think, the quality of your images, basically. Are you able to look at an image, say that image is of diagnostic quality? Do I need to repeat that image, and why? Or do I need to repeat it, or is there a pathology on there, for example? This is for sort of later on, though, but are you able to sort of begin to recognize these things? Can you notice the differences in images? Can you notice changes, things like that? We have plain film audit, which looks at our quality of images from reporting radiographers. Reporting radiographers do the actual reporting itself, and reporting is basically having an official comment from somebody that is trained in the interpretation of radiographic images. And the audit looks at the quality of our images, and it helps us and monitors consistency and accuracy of our images. So can you accurately position for a chest x-ray? Can you accurately position for an abdominal x-ray? And can you tell that they are good enough quality, that they are diagnostic quality? And do you have that attention to detail that can say, actually, I need to do that again? Because you need to think about how the clinical history of an x-ray request relates to the image that you've acquired, and whether you can say, okay, that image is of diagnostic quality, I don't need to do another one, or actually, I've missed a bit of anatomy off, that's important, I do need to do another image. And if so, what image are you going to do, and what are you looking for? And I think we are at the end almost. You're an absolute hero, those of you who are watching / listening, if you've actually managed to make it this far. So, is it all worth it in the end? How much do you get paid as a radiographer? People think, oh, it's a massively huge paying job. Starting at band 5, which the NHS has pay scales, starting from, I think, band 1 or 2, right up to band 8A, and then the rest is in consultancy grade. Radiographers, band 5, most recently in 2016, we start off, if you qualify it as a band 5, at £21,692. It is up to you whether you decide whether it's worth it. I personally think that this career is incredibly rewarding, helping doctors and imaging people and being able to answer questions. But that is for you to decide. If you want a whole presentation on whether you think it's worth it or not, and everything else related into tying in with on-call and how much you can potentially earn, that's for a whole new other presentation. But that is your annual salary, your basic starting salary. You will get on-call, you will get overtime, nights, on-call, some hospitals. I wouldn't say it's all now, but that is your starting wage, and hopefully this video has given you some insight into what we do as radiographers in medical imaging, and whether it's influenced your decision to start a career in radiography. And thank you for watching. If anybody wants any advice, feel free to comment, and I'll advise you on how you can best go about deciding whether you want to be a radiographer. But if you definitely want to become one, I would highly recommend spending some time in a radiography department. Look up a radiology department in your local area and give them a ring. Don't necessarily ring the actual middle, ring the office. Try and get the name or a contact of a person, one of the superintendent radiographers. Try and get their contact details and ask for a day. See if you can go in for a day, or spend 3 days, or spend a week. Spend however long that you like, or they're happy for you to spend, looking around and finding out exactly what they do, getting an idea and a feel for the entire atmosphere, because this career is not something that you can just switch in and out of. Well, you potentially can, but you'll be doing radiography for quite a long time. If you do radiography, you tend to be doing it until you retire in your 70s. Well, it'll probably be your 70s or 80s, given our government. But it's a long-term career, and it's not kind of as if, oh, you work in an office, well, go and work in a different office, in a different office, in a different office. Radiology is very similar across the board. It's just sort of the specialities that vary between hospital and hospital. So if you're seriously considering it, go and look around at a hospital, find out for what the radiographers think that are working there, and go and spend some time there, basically, before actually committing to doing the degree. Because, as I said, it's funded as from 2016, as far as I know. Probably isn't funded now. So you're going to have to either fund it yourself or apply for a student loan, which is going to cost you a lot of money. And you're going to be paying it back for quite a while. So there is that to consider. But again, thank you all for watching. And you are absolute heroes if you actually manage to make it to the end of the video. Take care, everyone. And I'll see you, hopefully, in another video.